So good morning. Welcome to Ground Rounds. A few housekeeping issues. Before we introduce our speaker for today, we're broadcasting, so please remember to use the microphones to ask any questions. This is broadcasted to a worldview audience via Vimeo and YouTube. The recording is live and is always available for viewing afterwards. And for our viewers, if you'd like to submit a question, remember to text DeBakey to 37607. I want to remind everyone of our upcoming trainees activities. So that we have the CV Fellow Bootcamp, which happens in August 6th to 9th, and then the Open Aortic course is on October 22nd to 23rd. And I want to introduce Dr. Dominic Emerson. He is an attending cardiac surgeon at Cedars-Sinai in LA. He trained his cardiac surgery fellowship at Cedars-Sinai, and then he did cardiac transplantation or multi-organ thoracic transplantation at Cedars-Sinai. He is a leader of opinion in transplant surgery and robotic surgery. He was instrumental in the development of our own program in lung transplantation with the robot, and he's going to talk to us about robotic cardiac surgery applying technology to improve complex operations. Dr. Emerson.
Good morning. Thank you for the kind introduction and for the invitation to come and talk with you all. I'm one of the cardiac surgeons at Cedars. I spend a lot of my time working on and thinking about robotic cardiac surgery as well as heart failure and transplantation in general. And I'm going to chat with you a little bit about where robotic cardiac surgery is within the specialty, and kind of how that has evolved and where I think we're going with that. So my disclosures. And the other disclosure I should make is that some of the things I'm going to be talking about with the robot are very much off-label. Excuse me. So I think there's a growing sort of experience and body of work describing the safety of some of these off-label procedures, but the robot isn't approved for some of these things. It's a very narrow kind of window of approval. And so if you actually speak with the reps or the folks at Intuitive, they won't be able to actually talk to you about any of these things. For example, like aortic valve replacement with the robot has yet to be approved. That's probably coming, but just as an FYI going kind of forward on this. So I know this is a take on a Michelangelo work and not a Da Vinci work, but it seemed to be fit a lot better with this. And as we begin to talk about the robot in cardiac surgery, I think it's important to sort of remember where this all started and what the goals were at the point where they developed the robot versus where we are today. Something that's often forgotten about the Da Vinci robot, which again is the only currently approved robotic system for cardiac surgery in this space, in cardiac surgery within the United States, is that the robot actually began as a cardiac surgery robot. The designers envisioned a robot that would help with this amazingly complex thing of heart surgery rather than like inguinal hernias and thoracic surgery, which is where the robot is currently primarily applied today. And some of the earliest descriptions of the use of this system, or at least the system that kind of predates what we're using today, came from robotically assisted CABG. At the time, it was called, you can see up there, computer-enhanced CABG, and this is obviously before the marketing guys at Intuitive decided that robotic sounded way better than computer-enhanced. But one of the first descriptions you see here is by Moore, which came back in like the late 90s. And you can see the setup in this diagram that was obviously before we had AI to draw our pictures for us. And it actually looks very familiar. This is sort of what we do today. But what I really wanted to highlight is the invited commentary that came after this article by Dr. Damiano. It's really interesting, and it reads in part that this technology not only has the capacity to improve our ability to do conventional procedures, but in the future will likely allow us to perform procedures that are now considered beyond the realm of human dexterity. And I mean, doesn't that sound amazing? That sounds like something that we all want to get behind. And enthusiasm at the time for something like this was really quite fantastic. The thought was that soon we're all going to be doing these sort of computer-enhanced CABGs and everything's going to be great in cardiac surgery. And the thought was that it was going to transition like a laparoscopic cholecystectomy, that there's going to be a time in the near future, maybe the mid-2000s, when nobody's going to be doing an open CABG. And why not? You know, this was like in late 90s, early 2000s. There was a lot of transition into these new technologies. I don't know if you remember the In the Year 2000 skits, which is the Conan thing in the middle there probably. Actually, I may be the only one who remembers that. But there was a lot of exciting stuff going on. And in surgery in general, the early 2000s saw a lot of really important changes. Laparoscopic surgery had really revolutionized how we thought about most surgical procedures, general surgery procedures. And if you think about it now, like getting an open cholecystectomy is rarely done. It's something that's almost unimaginable. But in the late 90s, that was how you were getting it done. Most of those procedures were open. By the early 2000s, that had changed so dramatically, it was natural to assume that the next step in that was going to be cardiac surgery. But this is obviously not what happened. We all still have jobs that primarily include open operations. This is some of the data from the early adoption of this new robotic CABG procedure. And you can see that even when this was very new, very exciting, this is early stuff, adoption wasn't great. At least not for this first application of the robot in cardiac surgery. And these sort of results were not what people had wanted or expected. And one of the biggest issues really stemmed from this, which is that most centers who started the robot didn't continue. Trying to sort of adopt a new technology without proper setup in a very ultimately low volume way led to early problems, multiple early failures, and centers abandoned the procedure quite quickly. And the result ended up being this. This is where we are today. So currently only around plus or minus 1% of all CABGs done in the United States are performed with the robot. And if you sort of contrast that to, say, lung cancer operations, where close to 80% or more are now being done in a minimally invasive way, that difference is very striking. And I think that this really set us back in terms of the use of the robot within cardiac surgery, both because sort of we as surgeons saw this as a failure to get something off the ground, and it has that kind of stain on it after that, but also because the company themselves saw that there was really limited returns and elected to put resources elsewhere, which I don't think any business can blame them for. As a society, as surgeons, cardiac surgeons, I think we've kind of learned a lot from this early experience. And I wanted to talk a little later about how this has sort of shaped the way we went to teach and expand the use of this technology going forward. But then if we're at this point, why keep pushing? If it's been an uphill battle with using the robot, why do we keep trying to do this at all? Why change that? In short, why the robot? Why would we want that? Well, I think it's a great question because not only do we have some not the best history in implementing this technology, there are a ton of barriers in this space to robotic cardiac surgery. First of all, cardiac surgery is already hard. It's an exceedingly complex operation. There's little room for error, and you have this clock of ischemic time constantly ticking in your ear. And while little incisions are great, it's nice to be able to do it through a small working hole. If the patient doesn't do well, it ends up being meaningless. We have to prioritize outcomes at all times for these patients, and that has to be the first thing we think about. And speaking of outcomes, we're all tracked. Our outcomes are benchmarks. Anyone can see our outcomes and know how you as an individual or your center are doing. And the curve for this is extremely sharp. So this is just two centers I pulled off of STS. It's not your center, not my center. But what I wanted to highlight is that you can see that the difference between these two centers in their composite score is 1.3%. But that 1.3%, that small amount, is the difference between a 3-star program here and a 1-star program. So we're working in a very tight margin in a increasingly complex and difficult arena. And so adding the robot has to be done in a very thoughtful way with good reason. So why would we want to go ahead and do that? Well, I'm going to try to convince you today that the robot in cardiac surgery is actually really a true and natural progression of our specialty. And the tool actually facilitates an easier, safer, more teachable, more reproducible operation in many cases when applied correctly. And finally, I want to show that there are things that you can do with the robot that are simply just not possible with any tool that we currently have in the operating room otherwise. And you'll notice that in all this, I didn't mention anything about little tiny cute incisions, because while they are great and absolutely unquestionably patients want that, cardiologists are asking for that. So there is a huge push towards using the robot because of those reasons, but I don't think that that's the real underlying reason that we should be using it. I don't think that's where the robot really shines in cardiac surgery. I think it's these other aspects that I mentioned here. And to show that, I'm going to focus on a few different aspects of a couple of these operations. Maybe. Or possibly not. There we go. Sorry. My pointer died. So the first thing I wanted to focus on is what I think the kind of the single best application of the robotic technology is in cardiac surgery, and that's the robotic mitral valve repair. This is a kind of growing area and the largest kind of penetrance of the robot in cardiac surgery to date. And this is, I think, the space that it really demonstrates where the effectiveness and the use of the robot is. And the mitral valve itself is a tricky thing, right? Repair rates are currently just far from ideal, even in large centers. This is some slightly older data from Dr. Chikway's article in JACC a few years ago, and that you can see that rates even in some of the larger centers, so on the right side of that curve there, are not where we want them to be. Even in centers that are doing, 50 plus of these cases a year, the repair rates may be in the 50-60% rate. And that's despite the very clear evidence in the guidelines that indicate the repair is absolutely the gold standard, and we all should be shooting for repair in these valves whenever possible. Now, does the robot suddenly make us excellent mitral surgeons? Well, no, obviously not, but it does, I think, help facilitate the operation, and it does this in a few very important ways. And the first is exposure. This is a not so nice valve that I did the other day, and this is a bit of an extreme example, but the mitral valve exposure can be quite challenging. And if you're trying to teach with that, while you're poking your head in, able to see out of one eye, and then your resident has to come in and look, it becomes very, very difficult. And so advancing our knowledge of mitral repair and sharing that with our residents is something that can be very problematic. Getting them that exposure is not always easy. Additionally, to see, we end up pulling up and yarding up on that atrium, and that fundamentally distorts the valve, leaving in this sort of non-anatomic position that I think can affect the way that we understand the anatomy in the operating room and prevents testing it in the same way that it would be in a kind of a more normal physiologic state. And if you contrast it to this view, which is just my standard view from the robot, I think there's really no comparison. The robot provides a fantastic three-dimensional view with magnification and a sort of clarity that you can't get with your loupes. Moreover, because of these sort of wristed instruments that we have, there's a level of dexterity that just absolutely can't be achieved open. And for all the images and videos I'm going to be showing, it looks great, it's on the screen here, but in actuality, this is a really poor comparison to what you see on the console. On the console, it is even better than this. And this is, sorry. And this also allows as I was saying, a normal kind of anatomic evaluation of the valve. So when the retractor is in the atrium here, we can look at the valve. It's not pulled up on stretch. This is basically where the valve is going to lie in sort of real life. And it allows us to look at the valve, understand the anatomy, I think, in a different way. And anybody in the room sees this exact same view, so a better understanding for our residents who are watching as to what is kind of going on. You can see me assessing it with the hook here. Even our assessment at the end of the case, I think, is much, much better. A saline test here allows the valve again to be in a normal anatomic position and gives us a good sense of kind of what that is going to look like in systole. And one of the things that is also great about doing it with a robot is that it very much standardizes our approach to this procedure. Excuse me. And this may sound simple, like, oh yeah, standardization is great, but if you think about it, like at Cedars, for example, we have 3 surgeons that use the robot for the mitral valve. We all do it exactly the same way, with very small differences. And getting 3 surgeons who came from completely different backgrounds to do things all basically the same is really no small task. But through this standardization, I think we get a platform that we can apply the technology safely to a bunch of different things. And this is what that standard approach looks like for us. It's a cross clamp. We open the left atrium via standard left atriotomy. We don't dissect a lot of the groove out there because you don't need to with the robot. A valve assessment comes next. This valve assessment can be very detailed and is obviously augmented by what we saw on the echo, but you get a very good sense of what the pathology here. It's a posterior leaflet issue. What the pathology is, and can really assess length of the chordae very, very well with the robot. In this case, it was a simple triangular section that we needed to undertake. Chords, if you're somebody who prefers chords, is very easy with the robot. It can be facilitated very well. You can see deep into the ventricle. For us, the next step is using the cardinal suture, which, for those of you who don't know, it's effectively like a Prolene, but with less memory. It's great for valves. To reapproximate our cleft that we've created. Tying down with the robot is also quite easy, and bringing everything together. After bringing the valve together, we typically size. There are some sizers that were developed specifically for minimally invasive surgery, which you see used here. The left atrial appendage can also be addressed very easily with the robot. It's a small add to these cases. Some of us, myself included, like to close it effectively in every case because it's a small addition, and so we do that. It also helps to bring the valve over, letting us see it a little better. Placing the band is also quite simple. We tend to use we always use this very flexible band, which we take off the holder, obviously, and just drop into the chest. And this allows us to kind of progress through the band and shape it as we go, which I think allows a better repair, a more anatomic kind of repair for the valve. And then again, testing becomes very easy and gives us a good sense of sort of where this lies at the end. And obviously I'm going to show you a great one, not one that was super complicated because I'm trying to promote the robot, but in actuality, standardizing it this way, I think, really allows that to be sort of the norm in these cases. And the benefits of this standardization, I think, are very real and include sort of providing the surgeon with the exact same view every time. It allows a sort of routine to develop, which I think helps our residents and the rest of the staff in the operating room, honestly, understand what the flow of the case is, which in turn increases things like our efficiency in the operating room, how quick we can turn around because it's always the same setup, always the same pack. That seems like a small thing, but being able to do more than 2 cases a day is not a small thing, as I'm sure you guys all have experience. Maybe your turnover times are better than ours, but I think it's kind of a universal issue. And we can do 3 of these cases in a day. Now, it's not that I'm done by 4 p.m. doing 3 cases, but we can still manage to turn out 3 cases in a day. And for example, on Monday, I did 2 robotic double valves back to back in the same room, and was done around 5:30. So the turnaround, the efficiency really does improve with this. And then finally, I believe that by eliminating some of the other variables in the operation, by taking it down to really just the bare minimum of what it needs to be, it allows the focus to truly be on the pathology of the valve, which in mitral valve surgery for the surgeon, that's the crux of the operation. You don't have to spend as much time worrying about the setup and thinking about it, and allows you to really focus on the valve. And the results are good. Again, of course, I showed you a video where it looked so easy, but in reality, that's what most of these are looking like for us. This is here is some 10-year data from Cedars that we published a little while ago. It shows that our freedom from greater than, so in this case, 2+ MR at 10 years was about 92% at 10 years. Now that's granted the primarily that's posterior leaflet pathology, which is the most common, kind of easiest to repair. But even when you look at the more complicated pathologies, which is that sort of lighter purple line there, our 10-year outcomes were about 85% freedom from that issue. And so that's even in the Barlow valves, that's even in patients with bad bileaflet prolapse that we're cording and doing all these other things too. So I think the outcomes can be very good, very reproducible with this. And it ends up being done with operative mortality that, at least in our series here, was less than 0.5%, as well as generally low rates of morbidity. And of course, this data has been reproduced not just by us, but by many other centers. And this is an analysis from STS data by Dr. Garrison that was done fairly recently. And it demonstrates really superior results with the use of the robot versus the more conventional methods, including sternotomy or even a thoracotomy. So still highly selected patients that you're doing through a minimally invasive approach, but not robotic. And I think that data really indicates that there is something to the robotic approach. There is some real benefit, especially in this patient population, for doing it this way. And these sort of results, I think, are extremely important. It's very important that we start to promote these and we share that we can have extremely good outcomes in these patients, because at this point, there's, especially for those of us who are really passionate about the mitral valve, there's a big change in the way that the mitral valve is being seen by the world, by cardiologists in particular. And we're in a little bit of a battle right now, if I'm being honest. This is sort of practice trends fairly recently that we're seeing in the mitral valve space. And the rise of transcatheter repair, the rise of TEER, has been important in our patient management, but it is becoming a bit worrisome to some of us. I think that this uptick that you're seeing certainly includes patients that are maybe too sick to undergo intervention surgical intervention at all, and so this data is a little skewed, but that sort of downtick that you're seeing in the volume of surgical repair, I think there's something to it. I think that is patients that are getting drawn away from a surgical repair that probably should have a surgical repair that are getting pulled into the TEER space. And I think that the only way to sort of battle this trend is to maintain very, very reproducible, very safe, very durable outcomes in the surgical space. One of the consequences that we're seeing in this shift in the kind of use of TEER more liberally is the rise of patients that sort of look like this. This is somebody who presented after a failed TEER. And make no mistake, I think we're going to be continuing to see this as a growing sort of proportion of the patients that we're evaluating, and we have to be able to offer them solutions going forward. This guy in particular came to me as a young patient who was clipped after he had a P2 flail and came in and decompensated heart failure. They clipped him, but within a year, this is what he looked like. And so he came back, obviously, with some significant symptoms. And with the robot, I think that this is a very, not necessarily fun operation as anybody's ever had to do it, but it is very approachable. The robot is very strong, very precise, and it allows you to have the ability to do things technically that I think you can't do open with these really challenging clips. This individual had 3 clips, unfortunately, so you see me taking out all 3 of them. But what I really want to highlight is the amount of kind of very fine, detailed work you can do with this. For those residents who aren't as familiar with the clips, these things are not very big, so this is really, really fine work. They can be very incorporated, and pulling these out can be extremely difficult. In this gentleman, once we had the clips out, we could assess and determine, okay, what was going on with the valve initially, and then you can see the wide, unsupported area of the posterior leaflet with some flail and this big cleft. And then ultimately we can go ahead and attack that in the same way we would with any other pathology. And for this guy, fortunately, with a very good outcome and really no residual mitral regurgitation. One thing I want to point out that even though this pathology is obviously very different than that first video I showed you of a more straightforward posterior leaflet repair, the setup is exactly the same. So if you looked at the outside, you looked at how I got to the point where I'm looking at the valve in this, it is exactly the same for everybody else in the room. And it, again, is that same platform, that consistent base that we build off of, that I think allows a lot of freedom to intervene in different ways, depending on the pathology that you have. I wanted to switch gears a little bit and go back to sort of the topic that I started this with, which is the robotic coronary work. So this is a robotic mammary takedown, left ventral mammary takedown that was done last week, actually. Sorry. There we go. Okay. And so while, So while the data trends that I showed kind of earlier in terms of robotic assisted CABG are not that great, there has been a lot of change in this fairly recently. After this sort of kind of initial uptick, there was a bit of a downtick in the way that robotic assisted CABG was utilized within the United States, but recently that data has indicated that that is kind of swinging back up. So now we're above 1% of all CABGs that are being done in the United States. This is STS data. And I think that that is continuing to grow. And one of the reasons for this, this change is the kind of dynamic that we have currently and have had for some time between CABG and PCI. I think historically we often look at surgical versus catheter-based interventions for revascularization as very sort of diametrically opposed, like two warring armies. I think we have our patients, they have theirs, and there's not a lot of love lost, if we're being honest, on that battlefield. But there is another area that I believe, this is another area that I believe the robot can be sort of helpful. And it can help by bridging the gap in that middle ground, which is hybrid coronary revascularization. And specifically, I think in my mind, and I think in the mind of others who are using the robot in this space, hybrid coronary revascularization really can't exist without the robot. The value of the sort of Lima LAD is absolutely indisputable. That is the best thing we can offer for our patients in terms of revascularization. And the robot allows us to marry that well-known, reproducible, excellent procedure with PCI, and you can have a really fantastic result in the right patients. Specifically, in my experience at our center, this middle ground, this hybrid space, is where most of the growth has come for these patients, for our mid-cab volumes. They're patients that are that have some degree of multivessel disease. I think that's where the growth in this space is definitely going to be. Waiting for just the patients that have isolated LAD disease is infrequent, and so it's harder to grow there. And the justification for using this approach stems from the generally very good outcomes with robotic coronary cases in general. The ODE ratios for these patients, this is STS data from Dr. Bonatti, are generally very, very good. And the longer we have experience with this, the better those outcomes tend to be. And in particular, hybrid cases using a mid-cab approach carries also some very real and very important, because ultimately the administrators really, really like it, outcomes in terms of cost benefit for our patients and for the centers. And so that, I think, is also driving this renewed interest in the use of this support, this methodology in coronary revascularization today. Now, there's some real challenges with this approach, and one of them is the learning curve. And while learning curve, I think, is a real phenomenon, it's present in anything we do, I think it's very hard to define. So I'll say that before I kind of show some of the data on learning curves, because I think it depends on who you are. I think we all learn differently. It varies tremendously from center to center and person to person. But it is something that we have to think about. And for example, this is Dr. Halkos's paper that came out about I think a year ago or so, looking at their first 1,000 mid-cabs that they had done. And they found that there were real noticeable reductions in mortality and procedure time, in length of stay, some other variables between the first and second 500 patients. And that's graphically represented here. The curves really started to flatten around the 250 or 300 range, and the authors concluded that sort of mastery in this procedure, mastery in robotic coronary procedures, they thought would take somewhere between 250 and 500 cases. And that is a lot of cases. And while I very much, I think Dr. Halkos and his group are fantastic, I think they've done really, really great work to help promote this, I would argue that I don't think that this sort of fits for everyone. I think it does indicate that there's a real learning curve in the robot, but I don't know that this is necessarily gospel. I don't know that this is going to be everybody's kind of path to mastery in this thing. I do think that it indicates, however, that we need to take a slightly different approach to learning this technology versus how we both traditionally teach open surgery, and more importantly, how we have historically educated people in the robotic space. And for us at Cedars, education, I'm sorry, imagine that this is a great video of me teaching. So for us, education begins in the sim labs. This is my resident working on some pig hearts with the robot. But it moves pretty rapidly into the operating room, which is something that our trainees can actually do quite well because they all have experience with the robot from general and thoracic surgery. Unlike people who were trained the way that many of us were, the way that I was trained before the robot was part of the general surgery curriculum, and we had to learn it much later completely from scratch, the folks coming through now have a very different understanding of the skill set, which I think is really important. It's a different base. And just to sort of prove to you what that looks like, this is the video that I showed you earlier, and to be honest, this isn't me. This is not me operating. This is one of my senior I6 residents, and they're on one console, I'm on the other, and he's doing it. And because I can really see not sort of what they see, not 180-degree view of what they see like you do when you're assisting somebody, I see exactly what he sees. And I can take control whenever I want. I can give control whenever I want. Teaching the robot becomes really exceptionally easy once you get used to it. And this is what the setup looks like. This is myself and one of our other trainees. Literally, you're just sitting right there. I can reach back and smack him if I need to. It's a very, very easy thing. We're both transitioning very seamlessly back and forth from one and taking control to the other. And here you can see, this is Rishabh, one of our fifth-year I6 residents, or now I guess as of next week, sixth-year I6 residents, working on the Lima takedown. And you can see these little blue arrows kind of popping up. So that's me. That's me using the other robot to direct him, pointing at things that I want him to do. There's no audio here, but they can hear me through their headsets as I'm speaking. And so you can really direct and kind of help them get to where they need to go on the robot. And with this, education on the robot becomes really a lot of fun. It is a great, great thing to teach. But again, I think this is fundamentally a different way of teaching than we as surgical educators in the space used to do, or the way that we're used to teaching people. And I think that actually that is one of the major challenges that often, unfortunately, gets overlooked. We talk a lot about how are we going to educate people, how do our learners need it, but in actuality, we as the educators have to change and learn and adapt to this technology and the ways that we want to teach it as it evolves. And so a lot of it really is on us as educators to people who are using the robot to kind of develop our trainees in the right way. And the STS has really taken that to heart recently, based in part on the prior sort of not great outcome or great start to the use of the robot that I mentioned, and thanks to some great work by Dr. Badwar and some others, they've come up with this consensus statement for training on the robot. This is on the, or was published in the Annals. It's easily available to everybody. And I think it's a great work that kind of addresses much of the learning that we're doing on the robot. Excuse me. Although obviously this is a very blanket statement, and so it's meant to be applied to a very diverse group of surgeons with different backgrounds, so it's inherently a bit imperfect, but I think it does well to address some of the gaps that we currently have in training, which have caused problem with program creation. And it's probably, I think, ultimately, well, again, great. In many ways, it's not as applicable to some of our residents, in my opinion. And I think that's because, again, they come from a sort of different understanding than we're used to. And in fact, they pick up things that and come from a different background, even outside of surgery, that allows them to understand and grow to this technology better. And to kind of illustrate that, I have this. This is my daughter. So that's her on the left, like 6 or so years ago, when she was, actually more than that, 12 years ago, I think, when she was about 6 or 8 years old. And then that's her on the right now. She's 18 now at Michigan, but she came with me to AATS this year and got to sit on the robot. So even though she's not a surgical resident, and even though, despite my continued best efforts, I don't think I'm going to convince her to go into medicine, she's had robotic experience. And so, you know, if you have a trainee that's coming up who has maybe not this level of experience, but the things that they're used to seeing and the things that they're used to interacting with are very different, I think that gives them an edge. And I think that we have to think about that when we're educating them. And I think the future is very bright for up-and-coming surgeons who are interested in this technology. And it's just not the prior experience of the people that you're training. It's also, at least in the mitral space, the environment in which you're practicing and developing these individuals that really matters. This is our looking at around 1,400 robotic mitral cases that we had done. And we found that within the training environment that we have, where there are multiple surgeons supporting and mentoring, the learning curve, which we measured by the sort of O to E ratios, really peaks dramatically earlier than had been previously shown. Here in the middle panel, you can see that the ODEs really start to come down after not hundreds of cases, but just under 100 cases. And additionally, this learning curve seemed to get shorter and shorter the more overall institutional experience that there was. We had surgeons starting at different time points at Cedars, and the ones that started later, as you can see in that sort of busy kind of graph on the right, had a shorter and more abrupt learning curve, and were able to do their early cases much safer because of the support system that we had. And so this goes to show that a really kind of thoughtful, structured education in this space is really key, just like, honestly, any other procedures that we're learning. And we've been able to apply that excuse me, to our advanced fellows as well that have come through. This is Derek Tam, who's standing next to me there in this picture. He was a robotic fellow with us for about a year, and we were able to get his robotic program going up in Canada. This is the first program in the province. He started it from the ground up and has done very, very well. And I think that this success just shows how good training in the right environment can start people off on a very different path than we had historically seen in robotic programs that were starting. And it's just an example of how adapting to this different learning style and looking at it in a different way can really facilitate the ongoing growth of this technology. And the farther we go, the more we adapt and adopt this technology, the more the robot is going to continue to push into cardiac surgery. And this is definitely happening right now. One of the most significant kind of emerging areas is within robotic AVR. Now, this is, again, as I mentioned earlier, this is sort of off-label stuff, but I think it's really kind of expanding dramatically right now. Dr. Badwar in particular has really done a tremendous amount to advance this in recent years. I think that the lack of approval that we currently have is going to change probably in the next year or two, hopefully. But even without that approval yet, RAVR seems to be very much here to stay, and the outcomes, as you can sort of see on that right column, have been very, very good. Now, granted, small centers that are very highly specialized, but I think that this is a space that is exponentially growing right now. And part of the reason it's been able to take off so well is, again, that standard platform of setup. Now, you think robotic, AVR, MVR, they must be significantly different, but the outside actually looks the same. The setup's very similar. Port sites are the same. And when you get down to it, as you see me come in and see the valve, the view you have, very different valve, but it in many ways is the same view. The motions that I'm going to be doing with my instruments are basically the same. And so developing that understanding of how to use the robot in one valve space, in the mitral valve, has allowed a kind of rapid adoption, a rapid pivot towards a completely different valve, a completely different area in the aortic valve. That's also kind of expanded. Sorry, it stopped there, but that's obviously expanded. Dr. Bradwar's reported doing, valve repairs, these sorts of things, and I think that kind of space is just going to continue to grow in the sort of natural progression of the. There it started again. Sort of natural progression as we learn more and more about the aortic valve and the aorta as well with the robot. You can see that the operation fundamentally is very, very similar to what you would be doing in an open case. Pledgets on the ventricular side, nice debridement of the leaflets. These can be done both in AS and AI. Obviously, the AI is a little more challenging in terms of resting and these sorts of things, but with direct coronary givers, it ends up being not a problem. There's generally a very, very good view of the coronaries, and so you can be very safe in how you do it. Placement of the valve is very well facilitated by the robot. You can kind of sneak it down in there. And then all of that ends up being tied down with the Coronat device, which is highly utilized in the robotic space already. The aorta is closed with just a simple running proling, as we would do normally. And then the rest of the operation sort of progresses in a very quick manner because there's no sternotomy to close. In addition to coronary and valvular disease and expanding into the aortic space, there's recently been an expansion into the thoracic transplant with the robot. We at Cedars were very fortunate to be able to lead this in lung transplantation, and the Saudi group followed shortly thereafter with the first robotically implanted heart. This is me and the surgeon who performed the first robotic heart transplant at ICHLT, which is one of the reasons that is a fantastic meeting, just because there's just a lot of different individuals there. But I think that was a great example of sort of where the robot can push into. But interestingly, even though it seems dramatically different, right? Robotic lung transplant versus valve space, I mean, those seem like completely different things. The setup is basically the same, at least on the right side, as we would do for robotic MVR. So again, we're building off that same sort of platform, that same understanding of how to leverage this technology in the best way and applying it to a completely new thing. I'm going to move through this really quickly because it's not really the crux of my talk, but you can see that because of the wristed nature of these instruments, these needle angles, which open in a cone down space from like a small thoracotomy or from like a sternotomy, can be very difficult. These needle angles are actually very, very simple with the robot. And as you get going, see me taking the bronchus here, it becomes very, very natural, very, very easy to do. Obviously, it takes some getting used to at first, but it's something that can be done very well, and in our experience can also be taught very well. We're teaching these procedures with our residents, our fellows, and they're able to take part of this as well. And we've gone through and educated other people with it, which has been really fantastic. And it truly allows a minimally invasive approach for something that historically has been like the absolute prototype of maximally invasive, right? Taking a clamshell incision and being able to reduce it to something like this, which is, I think, truly, truly impressive. But sort of as with any approach, the only value there is if we can reproduce it in other centers. And so we've gone and done some wet labs. I've taught some groups, and I mean, as you guys, I'm sure all know, that has, I was here like about a year ago, 9 months ago, something like that. And your team here has since done multiple robotic lung transplants have been very successful in that, and I think it's really fantastic to see. Hopefully other centers are continuing to pick this up. So I think that, again, this is just more evidence that this technology is pushing farther and farther into our everyday lives in cardiac surgery and transplantation. So where do we go from here? Well, I think that the next 5 to 10 years is going to see a real evolution in this technology. I think this is going to be driven in a large part by the new machines that are coming to market. So until now, as I mentioned, there's only been one group that's Intuitive, right? They were the first to the field. They had a lot of patents, and sort of fortunately for us, but maybe unfortunately for them, many of those patents are starting to run out. And this has opened up the space for competition, which I think is going to be very good. I think it's going to be great for innovation. The first to market in the US was going to be the Hugo, which is the robot I'm showing right here. They're seeking a cardiac indication for the robot. They don't have it yet, but that is going to be coming. Other robots are certainly going to follow. And I think this is going to drive significant progress in the field in all aspects of surgery, but especially within the cardiac surgery space. But perhaps the most significant change that we're going to see is going to be the layering in of AI in the robot. And this may come in many different ways. It may be in the form of augmented information that helps make surgery safer and easier, which is already in development and there are prototypes for. For example, this is being able to see and toggle between a layered 3D scan that's kind of digitally put in over what you're seeing, so that you can almost see inside of an organ to whatever structure you want to look at as you're operating. Additionally, the data analytics that are going to be available are going to be really, really impressive. The newest robotic model, the DV5 from Intuitive, tries to capitalize on this by taking all the data as you use the robot. There are some definite issues. Many of us have some concerns, or not as excited about this because there's a little bit of maybe suboptimal transparency with them right now. But hopefully in the future, that also is going to be a resource that we can really leverage to better understand how we as individuals and as a society are doing the operation and where we can improve. And perhaps the pinnacle of this development and the things that are going to be coming is the development of a true robot. And so what do I mean by this? Well, sort of the device that we all call the robot isn't actually a robot. I don't know, why do I wait till the end to tell you that? But it isn't. So a robot has some degree of autonomous ability by definition. The robot that we use does not. It is more like a fly-by-wire telemanipulation. It's going to mimic exactly what you do, but there's no part of the operation that is done autonomously, which is incidentally one of the most common things that I get asked in clinic by patients is the robot doing the operation? The answer is no, I'm doing the operation. But that's only for now. I think that there is a real chance that in the future there's some degree of autonomous action that's going to be taking place. And early work on this is already happening. The group at Hopkins reported this not that long ago, where the robot was independently able to do some parts of a cholecystectomy in a model. Obviously, this is really early. This is an explanted pig liver block, but it's not that hard to imagine that some element of this technology is going to make it into our daily lives at some point. That there are going to be aspects of this operation that are maybe not completely driven by the robot, but are definitely taken over in some way or another by the robot, by this machine learning of the device. So in conclusion, just to wrap up, cardiac surgery, or the robot, in cardiac surgery is absolutely, unquestionably here to stay. The numbers, the volumes, the way it can be implemented are constantly growing. There's new stuff all the time. And I think we kind of have to get behind that. And because of this, I think our education, our trainees, they're eventually going to need to sort of expect to see robotic cardiac surgery as part of their curriculum. We're already seeing it in the thoracic space. All the training programs now have some element of the robot that's being taught. And I think in the near future, we're going to be asked of that as educators to have that as part of our curriculum, and those that don't have that at some point will start to fall behind a little bit. And although I purposely kind of not really hammered this point, I think that the fact of the matter is that patients and referring cardiologists want this. Most of my outside referrals that are coming outside of Cedars come specifically for robotic approaches, and that's only going to increase. I have patients that come out of state only because they found me on the internet while they were looking up minimally invasive approaches to cardiac surgery, and that's helped our institution grow its volume, helped me grow my volume, and I think that patients are much more savvy. They're looking for this. I think that's going to continue to expand as time goes on. The wristed instruments of the robot provide a dexterity that is really ideal for the highly technical aspects of cardiac surgery, and it allows kind of a natural progression to the operations that we're already doing. And so I think that is another way that the robot can be leveraged in our space. And finally, emerging technology in this space is going to allow ongoing growth. And it's likely in ways that we can't actually predict at this time. Or sort of as Dr. Damiano said of computer-assisted CABG when he first saw it, that in the future, it is likely going to allow us to perform new procedures that are considered beyond the realm of human dexterity. And I think that is truly where we're headed in this space, and that's why I think it's important to embrace it now as it continues to grow. That's what I have. Thank you very much for the attention. I really appreciate the invitation to come and speak, and I'm very happy to answer any questions.
Thank you. This was a great talk, Dr. Emerson. Thank you for all the insight and for sharing your experience with us. My first question is, you showed us some data on how the learning curve for every one of your surgeons sort of builds on the learning curve of the whole institution, so it becomes easier to develop the robot as it permeates through the service. There's always in the back of every cardiac surgeon's mind the cross-mount time. Mm-hmm. And certainly before one completes their learning curve, or the team completes the learning curve, it seems like there is a higher cross-mount time with robotic micro surgery. Now, some managers have shown an association with mortality, others have not, but it seems like the median is, upwards of 120 to 150 minutes of cross-mount time versus what I'm sure is in your center, which is from 50 minutes to 70 minutes, right? And with the knowledge that as the center that has adopted this technologies has an easier time going over the learning curve, what are, in your experience, some of the things that you have done to try to mitigate the effect of prolonged cross-mount time as one tries to build on a robotic experience in more complex cases? I think that's been one of the Achilles heels for a lot of centers. Mm-hmm. They have seen a little spike in mortality when they undertake the adoption of this technology.
Thank you. I think it's a fantastic question, and I think a very correct observation in some of the barriers that we face. When I've gone and helped educate other centers and in trying to get our fellows off the ground, that sort of thing, in their own places, one of the things that I focus on, and one of the areas that people have problems, is just the sort of biting off more than you can chew too quickly. And so focusing on very straightforward pathologies as you're kind of growing that experience, I think, is key. I think where people run into problems is when they push out too much. Now, early on, cross-clamp times are going to be longer. The setup just takes a little bit longer. But there are definitely ways to sort of reduce that. And most of the early data that showed these much longer cross-clamp times was early in the sort of overall global experience with the robot. And the way that we generally are able to approach it now, I think centers that are starting or individuals that are starting that have a good platform that they built off of, so they did specialized time, they go to the STS course, they have, most importantly, probably a good proctor for the first few cases. I think they can kind of blunt that curve significantly. Now, it's not that it's going to be the same. Most centers are not going to start off with an average cross-clamp time under an hour for their mitral repairs, but I think that it can be done safely. I think that between that, redosing when you need to redose, the use of Del Nido, cooling to 30 degrees, which we've demonstrated has some real benefits for these patients as well. I think all of those things combined can allow a really safe implementation of this technology.
Thank you for patient selection. And looks great and rosy, and this is the recommendation, but some downsides to it. If there are issues during surgery, what do you do? I'm not a surgeon, obviously, but I'm just looking at where would conventional approach be the first choice, and what are some of the cautions required?
Thank you. I think it's also a great question. So I didn't get into it too much. I didn't want to get into the weeds too much with this, but as you're developing a program, that patient selection is very, very narrow. And the sorts of patients that people start out with, I think rightfully so, is very highly selected. Because again, you want to make the pathology something that is a little bit more straightforward, generally taking the patients that are going to tolerate maybe that longer cross-clamp time better, that sort of thing. There's been a number of different works that have looked at that. Cleveland has put out a whole guideline on what they think. I think their guideline is a bit sort of too conservative, but there's definitely some multiple discussions that have been had about where people should start out when they're starting programs in patient selection. There are definitely barriers. I think that the thing that I sort of group those barriers underneath is my ability to kind of rescue and have a plan B. And even today, with the experience that we have at our center, that's still kind of one of the ways that I think about the patients in selection is, can I bail you out if I have a problem? So, for example, if I'm doing a mid-cab, right, the idea is that that's going to be an off-pump cabbage, and everything's going to be great. But if it's not, and we have a problem, and I have to go on, I want to make sure that I can go on peripherally, that I don't have to worry about doing a stenotomy. I can just go on through the groin. And if the patient has like aortic iliac disease, and I don't think I can cannulate there safely, that's a barrier. And that changes a little bit as you evolve and you get more experience. But certainly at the beginning, that was one of my criteria. If I can't bail you out quickly, I'm not going to do it. There are a lot of reports and kind of these anecdotes out there about crazy, cool things that people do with a robot, and I think that that's actually a little bit detrimental to the expansion of the robot. We as cardiac surgeons love to kind of talk about how cool we are and like this crazy thing that I did last Tuesday and whatever, and I think that sets a different sort of bar and expectation for what we should be trying to do with a robot. And when you're starting out, I think the goal is to not do any of those crazy things, to do the very simple, very straightforward ones, get that institutional experience, get some N under your belt with a lot of wins, and then from there, that's the platform to build and kind of expand into the more complex pathologies.
Thank you very much. This is a great talk. I've been around for a long time, and I watched Dr. Damiano. He's showing these compared with the basic procedure 20 plus years ago. Ironically, you gave these words, but he's the first one who grew up and started to become an endoscopist microvascular. And through the years, in that 20 plus years, only the urology, things to urologists, technology stayed alive and never been adopted very well. And despite, powerhouses, that's, the Cleveland, the Mayo Clinic, the surgeons, always kept going this technology, but never been adopted. My question is this: what is different this time that you are confidently, optimistic about it to the entire cardiac surgery society will adopt it? I understand you can drive your car in the LA traffic with your feet, but it's not the real world.
No, I think that's a good question. That's one of the things that when I've talked to other centers and try to help them, convince their the administrators basically. So people who want to start it out, obviously, you can want to do whatever you want, but if your hospital's not buying you a robot, you're not going to get very far. And that's one of the barriers that they run into. Is like, well, why now? What's changed? You didn't like this 5 years ago. Now suddenly you're interested. And I think that the space really is different. So it's not as much as we want to say it's about us. It's not really all about us as the cardiac surgeons. The robot itself is more advanced, certainly, but it's the overall like worldwide experience with the robot that's different. So because of the urologist, because of GYN and general surgery and thoracic, the number of robotic cases, knowing how to kind of troubleshoot things, how to deal with stuff that's as simple as, you know, conflict between the arms hitting. There's a lot of people who understand that much better. And so we're jumping into the space, we're starting to continue to expand in the space with this different sort of understanding of what the technology can do. And I think that makes it easier. I think early on, it was very maybe ambitious to say that the first things we're going to do with the robot is cardiac surgery. I mean, that's definitely trying to sprint before you can crawl. And I think that was part of the issue, is that the understanding of the robot was not as good. And I think that our trainees now are different. You know, we have the ability to take them from sort of birth in their training and begin to understand robotic technology, minimally invasive technology in the cardiac space, which gives them a different platform to kind of build off of than we had historically. You know, getting a old grizzled surgeon who's been doing this for 30 years to use a new technology is not always as easy. And I think that's one of the benefits to getting our trainees to do it. And so I think it really is a different kind of space that we're working in right now.
Any other questions?
Can I ask one last question? Please, building on yours. I think I'm a newer generation surgeon. I see an inherent benefit in the robotic platform for mitral valve disease, and I talked about this last night. I have a little bit of a harder time understanding it in the wider adoption of robotic-assisted cabbage. And I'm fully aware that the discussion of revascularization for patients with coronary disease is very nuanced, and one patient differs madly from another patient. But when the bulk of the discussion of surgical versus interventional revascularization has been about patency, and there's been a big push for multi-arterial grafting and complete revascularization that has the longest results, how does that fit with the narrative of a hybrid approach? And how do you differentiate the patient that certainly has multivessel disease that is severe enough that warrants going to the OR, but at the same time, there's a decision being made that the non-LAD targets are better treated with coronary stents?
I think that's a great point. And most of that comes from a true heart team approach. So all of these patients that I see, with the exception of the isolated LAD disease, which is like a unicorn. I mean, it's not super common. All of those patients get presented. We talk to our interventional cardiologist, and we have a meeting. And my bar, and I think most of us that are doing this, the bar to saying, okay, I'll take that multivessel disease patient on for a mid-cab it's a pretty strict bar, right? It's pretty high. And they have to have a good syntax score lesion, the one that I'm not going to be tackling, a good syntax score lesion that ideally something like an isolated RCA lesion or something like that. And I think that we have to appreciate that the generation of stents that we have today, I mean, the cardiologists yell at us about it all the time, that the stents that we have today are really actually very good. And the early data on some of these stents is actually on par better than the early patency data for veins. So if you're just going to be doing a single vein and a lima, I for many cases, I think a stent is probably about equivalent. It is some patient selection too, and knowing what that timeline is. The 55-year-old guy with multivessel disease, absolutely not. He's not getting this. But 75-year-old person, primarily an LAD lesion, and then has some very great syntax score, chip shot lesion in even like the circumflex territory, something like that. I mean, that's a patient that I think does drive benefit from the lima to LAD. And who probably is going to do about the same with a stent to that other lesion versus a single vein graft. And they really do also seek it out. So some of these patients, a lot of the patients that I have are people that would not necessarily be seeing me at all or surgeon at all, that would be just heading for PCI alone. And if that's if we're clawing some of those back, if we're getting some of those patients back for the most important revascularization option that we have, the limited LAD, then I think that there's real value there.
Lovely. Well, thank you very much,
Thank
Dr.
you very
Emerson,
much.
for an amazing talk. And I want to say that you're the closer.
Oh.
You are our closer. This is the end of our grand rounds for the year. And we will take a break till September. So we will see you, those of you who are on YouTube channel, we'll see you in September 10. And I want to thank Dr. Kershaw Patel, who's the director of our grand rounds, Kimberly Hall, who has been, in touch with all of our speakers, and I think we're going to have an amazing cadre of speakers next year. So thank you for being here and sharing your information with us.